Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is implementing a fall risk screening and conditioning program. My name is Robin Malik, and I will be facilitating today's meeting. Please note the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by David Wilcox. David is an advanced clinician who has worked in the field of occupational therapy for 20 years. He started his career in 1998 at Moss Rehabilitation Hospital in Philadelphia, treating an array of diagnoses, including stroke, traumatic brain injury, spinal cord injury, pulmonary, and orthopedic conditions. David has extensive experience in not only treating the geriatric population, but performing environmental assessments to help prevent or reduce falls in the home. Throughout the years, his role expanded from treating clinical student supervisor, guest lecturer, mentor, and adjunct professor with specific focus on neuroscience, cognition, and activity analysis. David joined Biodex in 2010. As a clinical educator, he provides operation-based in-services, clinically focused continuing education, accredited courses and workshops, and ongoing clinical support for Biodex's line of physical medicine and rehabilitation products. He continues to work with clinicians and their patients, identifying how Biodex technology can assess and target specific impairments contributing to strength, gait, and balance deficits across all populations and diagnoses. And now, please welcome David.
Hi, everybody. Robin, thank you very much for that introduction. Welcome to you, everyone, for attending this fall risk course. I really appreciate you guys being here. It's the middle of the day. With that said, I'll get going right here. So one of the things that the name of this course is Falling Through the Cracks, Identifying Seniors at Risk Through the Implementation of a Fall Risk Screening and Conditioning Program. And I kind of came up with that name because I just find that there's just a lot of people out there that figuratively fall through the cracks. You know, we kind of have to wait until something happens until we actually treat some of these, in this case, you know, our older or elderly population. So that's where that name comes from. And by establishing a fall risk screening and fall risk screening and implementation conditioning program, you know, we're being a little bit more proactive. You know, we're trying to identify who these people are and trying to identify them actually before they fall, before that something happens. Okay, so just some of the learning objectives. In the next hour or so, we're going to go over, we're going to set the table as far as looking at some of the three impairments that can contribute to falls in the senior population. There could be more than that, but that's what I want you to walk away with. That'll go into recognizing the importance of implementing a fall risk screening and conditioning program, and then what's included in a fall risk screening and conditioning program. Okay, so first off, I just want to take a look with some of the intrinsic and extrinsic impairments contributing to falls in the seniors. Okay, so balance. I mean, we all know what balance is. It's actually really complex. I never realized how complex it was until I started really doing research and looking into it. Not just as a clinician, but as a entry-level researcher. So I think of balance as like the engine of a car. You know, so everything has to be working in sync in order for that engine to run, okay? And really, if anything is off, if any one component of that engine is off, that entirely affects the entire engine. So in this case, balance, okay? And so some of these things that we need to be able to have good balance are working sensory systems, so information being able to come in through the various components of a vestibular, visual, and somatosensory systems. We have to have good neuromuscular responses. We have to have good muscles and joints under the musculoskeletal mechanisms. And we also had to have mechanisms within ourselves to be able to react, for example, to react to perturbations in the environment. So whether we're sleeping on black ice up here in the Northeast, being able to react quickly in order for not to fall. Two other things. So being an occupational therapist, I threw these in here too. We had to have ample cognition, and we also have to really consider the extrinsic environment, the task and the environment in which it's being performed. Okay. All right. So what happens? So let's just take a look at sensory systems. Well, we have changes in our vision. So we might, as we get older, as we get into our older years, we can have eye structure changes and, the onset of eye disorders. In the vestibular arena, we could have like a vestibular ocular reflex or VOR changes, just as part of that general aging process. Proprioception, that's the third system, so we have decreased blood to the mechanoreceptors, so that impacts the metasensory. Also, we might have musculoskeletal changes. So generally, we have a decline of muscle strength about 15% per year after the age of 60. We have changes in bone density, strength, tendon length, and flexibility. So these are just general things that happen as we get older. All right. Changes in cognition. I think of executive functioning or, not making good decisions based on poor judgment, poor insight. I can think of just from a personal level, my father is older, and he still gets on ladders at 87 years old, and he has very limited insight and does not make the best decisions. So that in itself just puts him at risk for falls and falling off the ladder. We also have environmental factors as well, and we all know as therapists and nurses what that's like. So the lack of lighting, the thick carpets, the cluttered environments that people can live in that just lead to trips and falls and slips. We have changes in our proactive and anticipatory mechanisms and reactive mechanisms. So this is, I've really done a lot of research on the reactivity and reactive mechanisms as we get older. And so, again, back to a friend that I know, was walking into his garage, and he tripped over a rug that's been there for 40 years. And as he was falling, he just fell right on his head. He could not react. He could not put his leg out in front of him to break the fall, could not even put his arms out in front of him to also break the fall too. And so when I was talking to him, he said, I could see myself falling. I just couldn't do anything about it. Like my body just wouldn't react, and as a result, he fell and then he injured his head. He snapped his head back. He's okay now. He's up and moving around, but still, that's that reactive mechanism where the reactive system of the neurologic system, as we get older, just doesn't want to react. And so as a perturbation comes into play, an external perturbation such as a slip or a trip, that can really impact a person's ability to be able to react quickly and not to fall or break a fall in this case. Okay, so here's just an example. I mean, you can probably pick many of those different mechanisms. There's a gentleman playing kickball, but this could be reactive. In a minute, you'll see him fall into the tree. But he just didn't have that reactivity. So as his feet started to cross, he couldn't react. So I think that was a good example of just that lack of reactive balance. But there's probably a whole lot of other things that are going on there as well. Okay. All right, so we're going to dive into the significance of implementing a fall risk screening and conditioning program. Okay, so just some fall statistics, it's well documented all over the place, that this is a huge problem. So just some of the statistics out there that I just wanted to point out. So 1 in 3 community dwelling adults 65 and older fall each year, leading to traumatic brain injury and hip fractures. And that number actually goes to 1 in 2, 50% over the age of 80. The problem is just going to get bigger. It's just going to get worse. And so, not only do we have that, these fractures and even deaths on top of that, but there's a cost factor that goes into us as well. So it's not going to get better. It's only going to get worse if something's not done. Okay? Well, with all these factors contributing to loss of balance in this age group, can we influence change? We absolutely can. All right? We can influence, as healthcare clinicians, we can influence the neurologic system, the cognitive systems, the muscular system, and some of those extrinsic factors that we see. Okay? For example, we know neuroplasticity happens. Well, neuroplasticity, the changing of the brain, the adaptability of the brain happens all the way up into our 80s and 90s. Not as much as when we're younger, but it still continues to happen. And we can influence that by, through exercise and activity. Cognition. Well, there's level 5 evidence that supports that physical activity with the geriatric population influences and impacts the frontal lobe and the hippocampus. Musculoskeletal, again, level 3 to level 5 evidence supporting that strength training in elderly population plays a huge vital role in the reduction of falls. And extrinsic factors. So we think of people's environments, so taking a look at those factors and being proactive and, strategizing how we're going to compensate, so lighting, carpets, clutter-free. But also another one is going to be medication. There are a lot of studies that talk about how more and more medications are going to directly lead to increased falls risk. So really taking a look at the medications and hopefully reducing those medications so that would reduce the possibility of falls. Okay. Everything is got to be science backed, so we got to have the evidence. So these are just a couple studies I just wanted to throw out there. There's a million of them like this, but, this isn't anything that we're making up. It's not anecdotal, everything is backed by science. So these are just a couple of studies that look at trunk strength, that look at exercise, and how much of an impact that they can have on seniors and the reduction or prevention of falls. Okay. Well, now that we know that fall interventions work, where do they start? Well, they start with a fall risk assessment. All right. So by definition, evidence-based fall risk assessments are brief checks to look at patients or residents who could be at risk for falling. Okay. We need to put it out there. We need to be able to quickly assess these people who could be at risk for falls and be proactive about it. Again, there's just some more quotes, some more science behind it. The implementation of a fall risk prevention program is important to ensure safety. Systematically assessing residents' risk for falls and implementing appropriate fall prevention interventions can reduce the number of falls in elderly and long-term care residences. So it's happening all over the place. It's not just happening in people's homes and in the community, but something has to be done in long-term care and other facilities as well. Okay, it's just more highlighting studies. This is pretty cool. This, when compared to control groups, fall prevention programs such as the Otago program, and I think, what else did I read? Tai Chi programs reduced falls in 55, 35, and 30% in these three respective studies. So it's not just 3, 5, 7% here. I mean, we're seeing significant changes if we're being proactive and we're establishing we're looking at fall risk assessments and then taking it to the next level and then having them engage in these fall prevention programs. Okay, so I look at this as two sides of the coin, the benefits of implementing the fall risk screening. So obviously the first side of the coin, while reducing falls and being proactive, again, I can't stress that word more often than not. I'm going to probably hear me say it 1,000 more times. It's just being proactive. But obviously, if we're able to intervene and assess and hence put them in, recommend fall risk programs, prevention programs, then there's going to be less falls, less hospital admissions. But you're also promoting active aging. This is a term that was coined by the World Health Organization back in 2012. Just basically, the word is prevention. Again, proactive prevention. Getting our elderly people to live as long as they can, as healthy as they can in the environment that they love. Okay? Flip the coin over. Well, I've been in some lower management positions as a therapist, so I have seen the business side. Healthcare is a business. So, looking at the business angle or the other side of the coin, think about what it can do by identifying people. Well, you're going to have a direct impact on the generation of revenue by an increased referral to OT and PT, outpatient basis, inpatient basis. But also, it's also going to help increase recognition. So I've actually worked with a facility up in northwest Ohio in their marketing department, and they are marketing to all their area seniors. It's a city outside of Toledo, and they have a huge geriatric population that lives in their area, and they have been marketing to their seniors for the last couple of years, and we do a fall risk event once a year on Fall Awareness Day in September 25th. So it's a great marketing opportunity as well. Get your name out there. Less falls, less lawsuits. All right, and then of course net benefit and return on investment. So the money that you put in and the money and what you're getting out of it, there's a significant return on investment. Okay. Hold on a minute. So let's just take a look at the last three. That's why I have bolded those. Okay. So decrease in lawsuits. So according to American Nurse Today's most common malpractice claims, it says that the failure to follow standards such as instituting or not instituting a fall risk protocol and then also documenting are two of the highest things of leading to lawsuits. So I found that pretty interesting when I saw that. Documenting, I always knew, but the fall risk protocol was something that was interesting when I came across it for the first time. Okay. All right, going back to that return on investment, again, we're kind of looking at that other side of the coin at this point. Well, actually, both of them, because you see 55% fall reduction. So that's important because that's leading to less fractures, less TBIs, less deaths. But look at the net benefit. There's a significant ROI in each of the three studies. And again, going back to how they did this is that there was an Otago program and also a Tai Chi program. These are just some of the programs they use after that assessment is done. Okay. So the components of a fall risk screen, what does it consist of? Okay, I'm just going to play this here for you. This is what I got from YouTube, but this is all over YouTube. You can really you have your pick of what you want to do as far as how this fall risk stuff is really out there. And it's out there in the public, it's out there in the media. So I'm going to play this for you.
Falls are generally considered accidents, but more and more they're being looked at as preventable.
There are many reasons why people fall. As you get older, you get cataracts, your vision is not the same. Some people develop neurologic problems, so there are lots of reasons why people fall.
Falls have significant health impacts. Nationwide, they're the leading cause of injury death in those 65 and older, and 30% of those who survive a fall will suffer an injury or broken bone, which can lead to further issues.
If you fall down and you break a hip, the chances of ending up in a nursing home are about 50%.
Dr. Sal Lacagnino works in preventive medicine. He finds you can lessen your fall risk by first assessing your home, putting grab bars where needed, and looking for hazards.
Even things that occur in the home. People have throw rugs on the floor that are slippery on the bottom, and they may just trip and fall because of that.
Getting your vision check and meeting with your doctor to review medications is another good measure. One of the best protections is to increase your strength and balance.
I want you to stand up from this chair 5 times without using your hands.
Lee Memorial Health System offers balance screenings and therapy.
We also work on what we call balance strategies, which helps you, if you do start to lose your balance, there's subconscious strategies that you use to help recover your balance before you actually hit the floor.
Taking a balanced approach may keep you upright and healthy. For Lee Memorial Health System, I'm Amy Osher.
I picked that video. I mean, there are a lot of videos out there on YouTube that highlight the importance of fall risk, but I like this one in particular because I thought it really kind of was pretty comprehensive, and it really talked about it really highlighted some of the things that we talked about already. The environment, inserting grab bars, in the bathroom is a common one. I mean, that's the most common one probably we all think of. I think they said, changes in vision. Those are just some of the sensory changes that we touched upon. The falls, the fractures, stuff like that. So I really feel like just this video kind of captures a lot of things that, just a little bit, just like sprinkles here and there as far as, what a fall risk, why these are really important and what can happen with the seniors and why it's important to, implement one of these programs. Okay. So, well, what does that consist of? So I look at a fall risk screen. Well, it's got to be relatively quick, so simple and relatively quick to administer. And from what I understand and from the readings that I've come up with is that, they're pretty lenient as to, who can give these fall risk assessments. I always thought, obviously, nursing, OT, and PT were the top three. For me, at least. But there are other disciplines that can come in that don't have to be extremely trained to be able to administer these, especially if it's evidence-based. Some of these tests or these assessments must contain a small number of items. It has to be transparent, meaning that, it have to be clear results, And on top of that, it's evidence-based scoring. So again, going back to the evidence, it's got to be from the science with good inter-rater reliability and that are valid. So not really pulling tests out of thin air, but using the tests that are already out there. We don't have to. What's nice about a fall risk screen is that you don't have to start from scratch. There are nice tests out there. I think I used Ability Ryan's lab, rehabmeasures.org, and you can choose valid and good evidence-based scoring tests that are between 5 and 10 minutes, so, and there's quite a few of them out there. There are more complex ones, of course, but in this case, when we're just screening, they're not in therapy, but these are just screens, then it's just something that can raise a red flag so that next level can be taken. Okay. Well, identifying high risk must lead to action. In other words, you can't check a box, and say that this person is at fall risk. It's kind of like a false sense of like you're doing something, not you, but that we're doing something, okay? It has to lead to action. What are the next steps? Once we identify that people could be at risk for falls through these fall risk assessments, what is it time for? We have to take some action. That's really important because I think that, I don't know what it's like for you guys out there, but, my parents are getting older right now, and this really speaks to me at full force. So it's very intuitive that something must have to happen. You've been proactive. We're doing our fall risk assessments. But it can't just drop off from there. That next level has to be that action. And sometimes action is just talking to the resident and saying, listen, there are some things that are going on right now that are leading me to believe that there might be, you might need to call your doctor. I think it's a good time for you to call your doctor and tell you that, and going into your doctor. Well, components of a fall risk screen. Well, first of all, you have the screen and then you have the assessment. So the screen is a little quicker, and then the assessment is a little bit more in depth, okay? So the screening is going to happen all over the place. Senior centers, community centers, IRFs, assisted living, geriatricians at the doctor's office. Again, going back to what I talked about a little earlier about that place up in western Ohio, northwest Ohio, it was a CCRC. So they had the assisted living, they had the independent living, and they had a SNF. And they were able to market to all the seniors that live not just in the independent living, but all over the community that didn't live there. Okay. All right. So screening. So according to American British Geriatric Society's fall management guidelines, again, it's evidence-based. Starts off with an inquiry about the history of falls over the previous 12 months, the frequency, the context in which it occurred, what the fall characteristics were, and self-reported deficits or difficulties that the resident is experiencing. At least one question about the resident's perception of difficulty with balance or walking too. And then an observation for gait and balance problems for residents who do report falls. So something really quick. This is something that can be done in probably 5 minutes. Okay? So in the screen, there are positive findings when the resident reports multiple falls, or the resident reports one fall and the observer identifies a gait or balance deficit. Okay, and that's going to lead to the assessment. So if it's positive, we go to the assessment, which is an individualized therapy multifactorial assessment for fall risk. Okay, so this is a little bit more in depth. Okay, so it starts off with an assessment for fall risk. So this is all part of STEADY. You guys might have heard this, but it's the CDC's fall prevention program. And it's basically a doctor or nurse, in some cases nurse practitioners, getting a baseline, looking at body functions and structure, activity and participation levels, doing a vision screening, getting a medical history, looking at medication, doing a medication review. That's really important. We know that medication is a significant reason why people can fall or may fall. Taking a look at their environmental factors, as well as personal factors. Okay. Then it goes on to a little bit more. So now there are 3 major components. We have a balance assessment. In this case, I picked 3 that you guys might have seen before. So one is going to be the Berg Balance Scale. That's a little bit longer though. So that's about 15 to 20 minutes. So that is a little bit longer. We have the functional reach test, which is like 5 minutes. And I don't know if you guys have heard of it, but it's called the Clinical Test of Sensor Integration of Balance, or the CTSIB, which is about 5 minutes. The next category is a gait assessment. In this case, timed up and go I chose, dynamic gait index, and a 10-meter walk test. And then the last category, we know that strength is a huge component of falls, so that's another category. We can do the 30-second sit-to-stand test, the manual muscle test, lower extremity function scale. Okay, so as therapists, we do manual muscle testing. It's a quick shot. It's not my favorite, but it's evidence-based, it's valid, and that's what we know, and we can get a gross muscle function out of it. Okay. So why use so many assessments, especially with balance? Well, I find that, balance is like as deep as the Pacific Ocean, and I just feel sometimes that I'm just kind of scratching the surface. As a result of that, all these different systems, remember the components of the engine. Everything has to be working well in order for that balance to be running well, that engine balance. As a result, there's no gold standard for balance testing. The balance system relies on many afferent or sensory signals and physiological systems in order to be able to maintain our balance. It also consists of, it's not just standing balance. We have static balance, we have dynamic balance, and we have functional balance. So these are just different categories of balance that we have to think about. It's really, really complex. And it's because of that complexity, it's construct that makes it difficult for just a single assessment to capture balance deficits. So, like I said, relatively quick assessments, but I find that the more that you can do, I'm a pretty thorough therapist, so that's why I would do as many as I could within a small time frame, because I want to be able to capture all 3 categories of static, dynamic, and functional balance. You guys, many of us have heard of it, a Berg Balance Scale. It's valid with well-established criteria. It consists of 14 items on a 0 to 4 scale assessing static balance and fall risk. A score of 45 or less is traditional cutoff for those at risk. So again, valid, good inter-rater test reliability, evidence-based, and something that we might be familiar with, or the physical therapist attending this will be. A functional reach test. This is actually really quick, and I like this. Maximal distance one can reach forward beyond the arm's length while maintaining a fixed base of support in the same position. So just some numbers right there. So that's going to be more of a dynamic test. You're out of that sway envelope. So you're really reaching forward. Okay. Also, CTSIB, there's a couple different ways that you can take a look at CTSIB. Being that it's the test of clinical sensory integration of balance. So this actually looks at 4 different conditions. Eyes open, firm surface, as you see that woman right there to the far left. Eyes open, firm surface, eyes closed, firm surface, eyes open, foam surface, and eyes closed, foam surface. So the first one, it's taking a look at the sway envelope and the sway index. So, eyes open, firm surface means that, you're going to have a relatively low sway because it's looking at the integration of all 3 sensory components of balance. Eyes are open, so eyes are included. Vestibular system is working, and the somatosensory system is working because of the hard surface. The next is going to be eyes closed, firm surface. So now the predominant sensory components of balance required for her to maintain that upright static position and have that low sway possibly are going to be the vestibular system and the proprioceptive system. But you took away the vision. And this is really important because from a functionality standpoint, I think of like people walking to the bathroom at nighttime, in the dark. And it really kind of comes full circle to me as a therapist. I'm like, well, why do we recommend that people turn on their lights when they sit in the edge of the bed, for a couple minutes and turn all their lights on before they walk to the bathroom in the middle of the night? Well, because when you start taking away the sensory components of balance, in this case, vision, you're going to have increased sway. And the more sway that you have, that's an indication of postural control or their lack of. And lack of postural control is a contributing factor to falls. Third condition is going to be eyes open, foam surface. So we could be looking at walking on thick carpets. We could be looking at people with diabetic neuropathy in the lower extremities, where you're reducing, not taking away, but reducing somatosensory awareness and seeing what happens to the sway. And then the last category is eyes closed, foam surface, whereas the vestibular system is the predominant sensory component maintaining that balance. So you got eyes closed, so you can't use your eyes, and you have a foam surface taking away the somatosensory. So the vestibular system is maintaining that static position. And you'd be crazy to see how people start to sway when they have their eyes closed on a foam surface. Again, from a functionality standpoint, if you kind of extrapolate this in a functional setting, these are our patients, our geriatric population. These are people, for example, getting up in the middle of the night, walking on thick carpets in a dark environment. Of course, if you take away 2 sensory components of balance, and they have to rely on 1 key sensory component to maintain their balance, they're going to be at fall risk. So I found that to be really interesting, a really good test, and it's really easy to be able to kind of extrapolate that into real function. So what's nice about this test is that it's on various technology, So if you use posturography, in other words, like in this case, you have real life data that technology, I find, can capture deficits that the human eye might not necessarily be able to see right away. We see subjectively that we see some changes, but even the smallest of changes that we might not be able to see with our eyes, with the sway in this case, is going to be captured through technology. So these are just some of the benefits of technology and how they can really support us as clinicians, and hence, help us make recommendations for that population. Okay, the gait assessment, timed up and go, the tug test, dynamic gait index, 10-meter walk test are 3 really good tests. Okay, timed up and go is less than 5 minutes. These are just the different descriptions of what these different tests are. Dynamic gait index, as well as 10-meter walk test. So I'll play this video right here.
For the timed up and go, you need to make sure that you have a sturdy chair with arms. You need to place it against the wall. And you need to make sure that it's stable enough to stand and sit in. We've previously marked 10 feet using a pre-measured rope, and we've marked on the floor with tape how far your older adult has to walk. JW, I'm going to demonstrate this test for you. We're going to have you sit down, stand up, walk 10 feet, turn around, sit back down. You've got 12 seconds to do the test, but I want you to walk at your normal pace. So we're going to sit, stand, walk, go past the line, turn around, and walk back. If you use a walker or a cane, you can use that for this test. If you feel unsteady, I'll be there to brace you in case you need help. Do you feel comfortable performing this test? Mm-hmm. All right, go ahead and have a seat. When I say go, I'll start the timer. We'll get up and walk. Make sure that you're in a good position to guard in case the person loses their balance. You ready? All right, let's begin. Ready, set, go. Great job. If at any point they lose their balance or they're unable to finish the test, go ahead and stop and mark that on the evaluation.
So I love YouTube. I mean, it's crazy what you can get on YouTube. I mean, videos like this where, you know, you have the written information as to how to do the test, but then you can reinforce it with videos on YouTube. So everything that you've seen today is actually from YouTube. So very educational, especially if you're a visual learner and you want to know how to do this. These are great just different ways to be able to access this information. It's become incredible. So again, standardized, relatively quick, valid, evidence-based, reliable, all the above, you know, and tests that we all, or at least some of us, can be relatively aware of and know that we do already. Okay. And then the last category is a strength assessment. You know, we have a 30-second sit-to-stand test, manual muscle test, and lower extremity function scale. Okay. Again, 30-second sit-to-stand test, less than 5 minutes, arms crossed. Sit-to-stand as many as one can do. Lower repetitions equate to strength and balance deficits. Again, I didn't include this, but you know, you can go to YouTube and see how this is done as well. Manual muscle test, you know, we do that. And then the lower extremity function scale is more of a questionnaire, you know, so with a maximum score, the lower the score, the greater the disability. So, I mean, there are other tests that you guys can use. I just found that these were some common tests that were, again, valid and everything else. I think I went to rehabmeasure.org, that, you know, these are just tests that I've used or I have seen physical therapists use as well in the past to help them make their assessments. So something that I'm very familiar with already. Okay. All right, components of a conditioning program. Okay. Well, evidence-supported exercise prescription for older adults. All right. So much like what we know already, it's got to be progressive and challenging. Okay, moderate to high intensity and most effective. I would say if we're going to have influence over the neurologic system and muscular system, I would say the first and foremost is going to be intensity. We really, within the boundary, you know, it's very patient specific, but intensity is really important, and it's probably the number one thing outside of repetition and practice. Standing with minimum upper extremity support. All right, so really trying to utilize those big muscles in the legs and in the trunk to be able to work on them. Okay, the dose. You know, I read 50 hours every 3 months that initiates in PT, transitions to a home program. You know, engaging in programs recognized by the CDC, such as stepping on, Tai Chi moving for better balance, and the Otago exercise programs are just three of these 14 studies. So lots of programs out there exist already. Frequency, no consensus. Evidence points to 1 to 3 times a week over 3 to 12 months for these programs. So, you know, something is better than nothing. And we just have to, you know, get them to be able to engage and do things. Okay. All right. These are just some things that I included. So we have static balance, and then, just look at the feet. These are just different ways to be able to grade and adapt an activity. So in this case, that first picture on the static balance, you have wide base of support, and that goes to narrow base of support, ongoing to semi-tandem. In that case, yeah. Or the next picture is going to be, it was supposed to be tandem, and then the last picture is going to, or no, one-legged. And the last picture is going to, take away certain sensory components, so really work on that balance. So there's just various things that you can do to work on that balance, but they have to be challenged. It's almost like you have to challenge them to the point where they're almost falling, because that's how the neuromuscular system changes, is by challenging them that much. Dynamic balance, doing things that are uncomfortable, but you know what? It's got to be part of it. Functional balance, in this case, doing dual tasking, pouring a cup of water while you're, reaching, doing things like that while trying to maintain the balance. And the last one is one of my favorites. It's perturbation training and reactive stepping. This goes back to what we talked about before, where, I think I was reading in one case or one study that 60% of falls that happen in the community happen because of reactive situations, perturbations. Slipping on the black ice up here in the Northeast. Being a traumatic brain injury therapist, I think back in 2015, I worked with 3 or 4 brain injury patients that fell. It was a huge black ice season up here in Philadelphia, and they were going out to get their paper or they were doing something outside. They slipped on black ice. They had poor reaction. They fell backwards, and they had significant traumatic brain injuries. So I've lived it, not myself, but I've treated it. But we know that neurologic system can change. We just have to put that system under a situation where they can train so it can change. So in this case, what you see this gentleman doing is that he's actually providing a perturbation. He's pushing this woman's shoulders, pushing her backwards, pushing her to the side, so she has to react, and it seems abrupt, but, it's great training for them. And in some studies, they find that just doing reactive stepping and reactive balance training can really change the neurologic system as early as like 1 or 2 sessions, but it's something that has to be trained. And, doing like lifting weights and doing an arm bike and stuff like that isn't going to help with reactive stepping and reactive balance. It's the actual situation of where they're under those situations where they have to practice it. I found that to be pretty interesting. And that's huge. I would say that most people that I've treated, and now, like I said, it's on a personal level, my parents, that reactivity or their lack of is a huge issue. And so I just find that I'm just waiting for a trip to happen coming up the stairs, or a trip over a rug, where they can't really react. But, okay. Just different strength trainings, lower body, postural muscles, really important. Minimal upper body support, moderate to high intensity. Again, goes back to what we talked about with balance. This is interesting. So training alone does not impact balance, must be combined with balance training. So strengthening muscles themselves not necessarily translates to balance. Okay, they have to be together. Okay, because of that neuromuscular component, neurologic component. Dynamic gait training, dual task training, obstacle course training, treadmill training, changing direction to command, circling, figure eights. All these are functional movements that they're going to be doing in their home anyway. I just think of an instrumental ADL when they're in the kitchen and they're doing a meal prep or they're doing laundry. These everyday activities that they're doing home encompasses all these different types of movements and changing direction and so on and so forth.
Well, thank you so much, David, for your great presentation. We do have time for a few questions, and we have one that had come through during the presentation, and that is, there are a lot of exercise products on the market. If I had to budget for one product, what would be your suggestion?
It's a good question. Well, for the sake of this presentation, I'm not going to sit here and tell you like with my products. I do work for Biodex, but I would definitely say that you get a piece of technology that can do assessment and training, particularly with balance. I think that balance itself is so complex. And so the more technology that we can encompass with balance, the better it is from an assessment standpoint and from a training standpoint. I mean, technology is great because, you know, you can do a pre-assessment and then you can train, and then you can do a post-test afterwards to see if that training had an impact from the beginning of the session. And I've done that before. I've done the CTSIB on technology before, and I was able to make a better call as far as my recommendation to that person based on what the technology, based on the numbers that it gave me back. And I was like, you know what? Oh my God. Like, these were things I can't see with my eyes. And I got great clinical observational skills. I mean, I have, you know, I'm trained to really look at the small things, being a neurotherapist. But there is only so much that our eyes can do, that technology can take over for us. And that's really important, you know, in our recommendations. And even if you wanted to go forward from that, I mean, you can write some great goals and write some great assessments based on some of the numbers that technology give us. But I definitely think that balance that has an assessment piece and a training piece would be my number one.
All right, thank you. Here's one more that came in. I work at a rehab facility. Do you have suggestions on where to look for a good fall risk screening tool? I'm not particularly happy with our current screening tool.
You know what, they have, you know what, let me go forward with this. This is from another presentation, but sorry, I just wanted to, no, I didn't include it. Shoot. You know what, if you go on to study, so Google CDC study program, I keep a copy of it in my fall risk folder. And there's a nice little section on there that says, like, you don't have to reinvent the wheel. You know, go to programs that already exist. And then it gives a couple of examples. Like the Hawaii one, there's one, Queensland, Australia is another one, and they give a couple more that say, like, you know, don't reinvent the wheel, you know, utilize some of the programs that are out there already. Now, I didn't look at them per se, but I think they're good for like like the programs themselves. I don't know if that includes the assessment pieces as well. But you know what? That's a good starting point. Why don't you go Google CDC study, STEADI study. Yeah, because that's where a lot of this valuable information came from to begin with. Oh, yeah. So one more thing. I don't know if you guys have this, but my Pennsylvania license is due on June 30th. So like, and I'm not in the clinic that much anymore. So I have to get my CEs online, and I go one particular site, and they actually have like fall risk presentations there too. And I took some information. I think Weisenberg 2015. You saw like what is included in the assessment. I think I got that information from this presentation. So that's another access point too. If you guys are looking to kill two birds with one stone, so to speak, if you're looking for CEs and you're looking to learn a little bit more or look at another presentation, another angle on fall risk assessments and screening programs, you can go to these sites that give you these CEs. The one in particular, one that I go to, not advertising, but it's occupationaltherapy.com because it's AOTA approved. But if you're looking for additional resources, those are pretty good resources too.
And now for anyone interested in learning more about the Biodex products pertaining to fall prevention and management that Direct Supply offers, please help me welcome our fantastic product manager, Kelly Sullivan.
Hello, my name is Kelly Sullivan. I am a senior product consultant here at Direct Supply for our rehab category of products. Today we're going to be looking at a few products that fall under the Biodex line. Each piece will pertain to fall management, fall risk, and they're all going to be applicable within your environment. So one thing that I want to do is ensure that you have a full understanding of how each piece might plug in to the current program that you have. First, I would like to talk through a poster board that I have here that really defines the Biodex message and how they go about presenting their equipment. So we start off in the nucleus here with the why. Why is this person behaving the way they are, what is the condition then that we're going to be solving for, and these are the various different ways we're going to be doing so. So for instance, when we talk about practice and repetition, repeatable exercises, and also how that connects to intensity and increase and ramp up period, how that relates to muscle memory, how that's going to encourage neurological behavior and help with stability and gait. All of those pieces are going to fall within that solution mix. We also have here task-oriented training as part of that wheel in terms of that rehabilitation for the individual. That's going to be using all different sorts of muscle groups and ensuring that that individual is going to have a healthy outcome at the end of their treatment and their rehab. Then we move out to the outer edge of this wheel, and then we start looking at specific products that are going to be that solution. The what is going to solve for that condition that we're faced with here. So that is essentially what we're going to be focused in on here today. 3 pieces out of their portfolio will be addressed. They, of course, have more product than that really fall into a holistic solution for you, which we're more than happy to answer questions on after this product piece. The first product we're looking at today is the Biodex sit-to-stand trainer. It's a fantastic piece that is a great addition to any environment, whether that be a PT-driven environment or a wellness-driven environment. It really is going to allow for you to do some activity that is fully functional. When you think about what is the most useful daily activity, functional move for you on throughout life? Well, it's going to be a sit-to-stand, right? Think from the time you get up in the morning to the time you go to bed, if you were to tally how many times you get from a seated to standing position, it's quite a few, right? If you think about it. So someone who is highly debilitated or dependent that doesn't have the opportunity to do a sit-to-stand because of lack of muscle strength or postural strength, postural control, but really, really lacking any kind of mobility because of decreased muscle tone in their lower extremities. This is a fantastic piece that's going to allow for you to condition those lower extremity muscles to get you from that seated position up to a standing position safely, and incrementally give you the ability to do so in a safe way. So how I'm going to demonstrate this today is just, first of all, just point out a few things on the system itself. You have a seat here with a seat belt for added security for the resident if necessary. But I really want to point out here is that I can give you some weight assistance. So if I want to give you 50% body weight assistance, I just move this up and down quite easily to get to the poundage of assistance that I'm going to want to provide you with. And then in the back here, I have a wedge. The wedge works as a range limiter. So maybe from day 1, we flip that wedge down, and that gives you less distance to travel with that sit-to-stand activity. Day 1, I'm going to give you some additional weight assistance as well to make this activity more manageable. So come on in. We'll get you seated here. Go ahead and push back into that seat. There you go. I want you nice and flush against the seat. You look great. Hang on. Notice now how this area is nice and open. There's no pad, because a pad would mean that we have an obstruction in our natural ability to get from a seated to standing positioning. There are pieces out there that have some support in front of them. Now, it's not a biomechanical natural movement though to have something in front of your knees. It'd be like sitting in front of the wall there and then trying to get to a standing position as your knees hit the wall. Not easily done. So this is a nice wide open space. I can easily pivot you in and transfer you into the seat, and it's going to mirror a natural biomechanical movement. So go ahead, and we're going to go and stand up. Nice and slow. Good job. So we'd be doing whatever you would like to prescribe, whether that's a set of 2 sets of 10 or what have you. We'll have you sit back down. Progressively now, I'm going to change the weight that's on the system here. So let's have you stand up one more time, I'm sorry. We're going to change the weight now. We're going to offload it all the way back down to minimal weight assistance, and we're going to remove that range limiter. So go ahead and feel that difference. You're sitting much deeper into that sit. And now we're on day 10, day 12, what have you, and we've taken incremental weight away from that assistance. So now we're really focused on you using your own muscles to get you from that seated to standing position. But we've done this day in and day out. So now your muscle has increased tone and you're more comfortable with this movement. So go ahead and stand up again. You can feel that difference.
Yes.
So really easy piece to use. There's not a lot of complexities to it. And it's a nice small footprint. And it's going to be in a digestible price point for you as well. So I encourage you to take a look at this product for your community and your clinics. The next product we're looking at here is the Biodex Balance SD. It's an assessment tool that you can use in your clinic where it's going to allow for quantifiable, measurable data for you to assess that patient's baseline. Where are they at? What is their risk for falls right now as it pertains to their demographic information? With balance, we all know that that can change daily. So being able to have a timestamp and look into that change in behavior on a daily basis, weekly basis, and actually see what those finite data numbers are going to tell me, what that storyline is going to reveal, without just observable data is really important. I can print this information off, the reporting I can send off to a doctor. It's going to give me hard evidence on where that person was and how I progressively moved them to a more stabilized posture that's going to protect them from falls. So the first thing we're going to show is going to be on the screen here, the testing. So you have both training and testing available for use. If we go into the testing, you'll see there's 6 different tests that are available for me to choose from. Today, because we don't have time to get into all of the details of the product, I want to really focus in on one test called the CT-SIB. This is going to really work towards giving me information around proprioception and how they are spatially aware of their surroundings, their postural sway, their lateral control. You can see here on this screen, it's asking for a lot of information, demographic information. Really all we need is going to be date of birth. So here I would plug in the individual's date of birth. I would call out what gender they are, and then I would go in and address what height they are. And then next, I can go straight away into the training. And here, what I'll be looking at is the information that's gathered from the test itself. So you're not going to see the trace during the assessment. It's going to be a graphical image that I'll see thereafter the testing is complete in the results portion. All right, so I'm actually going to have you, I want your feet to be right on across the center line here. So the arch of your feet should be across that medial line. There you go. Centralize yourself. This test just requires a static platform, but with the balance tool that you see before you here from Biodex, it does have the capability of doing dynamic testing and training as well, where I can change the movement of the platform underneath the resident to challenge them as they progress in their recovery. So we'll go into the testing. The first test, there's one of 4 here in this particular STSIB test. The first test is going to be eyes open. He's going to stabilize himself, hands at hip, if you can, and try to stay as stabilized as possible for those 30 seconds. The second test would then be, I'm going to take away one of his senses. I'll have him close his eyes for that 30 seconds and see how that changes his behavior a bit. Thirdly, we'll be putting this balance pad on the platform, which is going to be an unstable surface for him to stand on. Again, another level of challenge for him for his body to relate to. And then lastly, I will take away his eyesight and ask him to close his eyes with the unstable environment. So first off, we're just going to show what this looks like for the eyes open portion of the testing. So we'll go ahead and hit start. we'll ask the system to collect the data, which means for those 30 seconds, it's going to pull in information and give me that data set that I'm looking for in the results. So it counts it down, and here we go. We are in the testing mode right now. As you can see, again, there's no trace for him to visually see or biofeedback with this particular test, because we don't want him manipulating the test in any way, shape, or form. Biofeedback, though, I do want to say is an important component of some of the pieces that we're seeing today. In the next part of this demonstration with the practice portion of it, we'll look at how biofeedback is essential to self-correctment. All right, nice job. So we'll stop there. As I mentioned, there's 4 pieces to this particular assessment. I want to show what this looks like in terms of the results page. Once he completes all 4 tests, it's going to give me data information as to where he falls within that normative data set. So we can see by postural sway, which is a really strong indicator of what their potential risk for falls is, how much sway variance there is, and then here where they fall. Are they at high risk in the red, moderate risk in the yellow? Are they in the norm? Or are they doing better than the average person within that demographic? So it's really good, intelligent information that's going to allow for me to see where that person's baselined at and where they're going to hopefully be tomorrow after I've worked with them. Below here, I can even take a look at that tracing, that feedback that you would see on some of the trainers. But here as the clinician, I can see, okay, exactly what's happening on the platform. Where is that movement happening? Are there any major motions happening that's repetitive, that is maybe a clear sign as to a condition that might be at hand? Next, we're going to be looking at the training piece, which I push this here on the touch screen. You'll see that there's 6 core trainers that we can dive into. There's also some new games that they've built in that are fun and interactive for the individual to partake in when they're not being assessed. So this is another way to, from A to B, see how we can improve via the training possibilities here. For today, we're going to look at the postural stability option. Once again, I'm adding in that demographic information quickly, and that's going to give me my normative data and what I'm going to be compared to. So here I'm going to set up a couple targets. First, we're going to focus on lateral movement. So when I hit start here, you're going to be moving back and forth to hit those targets. There you go. There's a score, there's a time, so I could be using those as measurables and improvement. How long are they able to tolerate the activity, and what that score is and how that improves over time. Okay, great. Next, I'm going to establish a target for postural sway. And sorry, I'm a little off there, but we're going to go ahead and what you're going to be is moving front to back. There you go. I can give them a little encouragement here and help or guidance. I can even make it more difficult by changing from static to a more dynamic platform underneath him to be a little bit more challenging in the sense of the training itself. There you go. Great job. And then I'm tracking all of this information. I can save the results. I can print them so I can again show some of those big gains from day 1 to day 10, let's say. The last product we're going to talk to today is the Gait Trainer 3. Which also has a music therapy component that we'll be addressing as well. So here on the screen, you're going to see there's an option for a gait trainer and a treadmill. So you can use this product as a treadmill as well, but obviously the significance of the product really is in the gait training capabilities. So I'm going to once again enter in the demographic information to ensure that I am able to pull up that comparative analysis at the end for that results page. And then what I'm going to do is I'm going to look at what the goal is based on the information given to me. So based on the age I had put in and all of the information presented, it's giving me a goal of 2.15 to 3.7 miles per hour as your gait. So we go into that. First we hit start, and then I'm going to ramp you up here. And you'll notice that there is biofeedback within this tool as well. And that's super important when we're talking about training, because it's going to give you information on how you're doing. So I'm going to hit begin gait training, and you can see your foot there. And if there's any information, so here we have some cueing. So it's going to tell you, if you were to have an imbalance in your right to left, it will say walk faster with your right foot, to give you a verbal cueing, or to give you a cueing here. It also gives you that visual so you can self-correct. We also can graphically look at, how you're doing left to right foot. If we want, we can add music to this as well. And the music component is a separate line item. But what's interesting about this piece of it is that I can select a song, and I can look at beats per minute. And that's going to correlate with how fast, how many steps per minute. So he's stepping right now at about 85 steps per minute. So when I go into music, I want to find a song that kind of mimics that, close to it. So probably 80 to 90 is where I want him. And then the music's going to kick in slowly, and you're going to hear a metronome hitting, so that it's going to give you some assistance in that mobility. What's great about this is when you're talking about a neuro patient, and we're looking at ways that we can drive home muscle memory, neuroplasticity, ensuring that there is that cadence, that drive of cadence that is going to continue on thereafter the actual session, which there's actually clinical evidence that supports that claim. This music piece is one way that we can ensure that we can incorporate that muscle memory. So this is great, good job. When we end here, we're going to look at some results, the results page. So the system itself is capturing a lot of data. And the data is going to give me some clear insight as to where that person's at with their gait stride length, their cadence, the coefficient of variance between their right versus left foot, how much time they're spending on each foot. There's going to be some clear tells if the person just had a total hip or a knee. We're going to know that the distribution is going to be off, but we can then record over time how it evens out, and I can show whomever, a doctor or family or whomever I want to, how that happened over time by date stamp, by each results page that I send over. This is great information for you too, right? It's probably pretty encouraging to see progression, right, versus just being on a treadmill and walking and not knowing if you're doing anything or progressing in any way. So it's an excellent system. It really is going to be a huge addition to your clinical setting, in the sense it's going to give you reliable data to really support the claims around a healthy gait and balance, for that matter, as well. Now that you've had a chance to see a few of these pieces, I wanted to talk a little bit about their chain that they have here in their messaging. What they mean by this is really talking to the person that is the more debilitated resident that's going to require more assistance, that person that maybe sits for long periods of time or potentially doesn't even have the ability to get from a seated to standing position. So that's going to be where we focus in on the rise from a chair, that sit to stand motion. How do we do that? How do we get that person rehabbed to the point where they're actually able to do that independently? As we move through the train here in their rehabilitation journey, we're going to see then the next goal will be to stay balanced, to have strong stability, to be able to independently have the strength to have that foundational grounding underneath them. And that, as we know now, since we've seen the product, can be done in various ways, whether that be through assessment or through actual rehab activities such as gait training. And then lastly, the final goal, we want that person fully functional. We want them walking, we want them to be safe, and we want them to be independent. So really, at the end of the day, it's a chain of events. It involves more than just one solution piece. As we know in the rehab world, it's an and and an and and an and. And in order to understand that full journey, we need to figure out how we go from one end of the spectrum to the other end in a safe manner.
Thank you so much, Kelly. And thank you to David for your time today. If you have any questions about the products discussed, please email us at webinars@directsupply.com. For more information about webinars, please visit directsupply.com/webinars. Once again, thank you for attending today.